Ladies and gentlemen, dear colleagues and friends of the ERN Reconnect Network, it's a pleasure for me to all welcome you to today's webinar. And I think it is the hottest day in Germany and probably in Europe today. But also we are covering a very hot topic. And I would like to open my introduction now. Edit my presentation mode. And the topic, today's topic is the transition from benign to secondary Raynaud's phenomenon. I think this is really a very, very important clinical issue. I think we as rheumatologists face this situation quite frequently. Patients coming in with maybe benign or primary Raynaud's phenomenon, and some of them are, of course, quite afraid after they have seen the internet what's going to emerge out of this benign phenomenon. May it happen that we will see secondary Raynaud's phenomenon, which may be indicative of a completely other situation. And so we are very, very happy to have two eminent experts here. I will just list them in alphabetical order. We will start with Professor Maurizio Cutolo, who is very well known. He's deputy chair of Reconnect. He's also the director of research laboratories of experimental rheumatology in the University of Genova in beautiful Italy. And then we come to another very, very nice country. We're going to Belgium to invite later Professor Vanessa Smith, who's also a strategic board member. She's a disease coordinator for systemic sclerosis and also the ERN Reconnect Young Working Group chair. In her second life, she is the head of clinics, Department of Rheumatology in Ghent, University Hospital of Belgium. So, as I mentioned, it's a very important topic. And of course, you cannot give a talk today without also going to ChatGPT, what I did this morning. And ChatGPT told me, oh, the transition from benign primary to secondary nose phenomenon is an important clinical concern as it can signal the development of a more serious underlying disorder, particularly in connective tissue disease like systemic sclerosis. I think that's wisely put by this AI system. And of course, Raynaud's phenomenon is a very, very important issue in the daily clinical life of rheumatologists. You see the typical picture on the right-hand side. And we owe the first description to Dr. Maurice Raynaud, who was born in August 34 in Paris and died in 81. And he described for the first time the Raynaud's phenomenon in quite very, very important details. So we will focus, as I mentioned, on the transition from primary Raynaud's phenomenon to secondary forms, and we will have two parts of our presentations. In the first part, Professor Maurizio Cutolo will discuss the causes and pathophysiological mechanisms underlying the transition from primary to secondary forms of Raynaud's phenomenon. And also very, very interesting in the second part, Professor Vanessa Smith will highlight the role of nailfold videocapillaroscopy, which we all like a lot, in detecting this transition and emphasize the importance of regular examinations with this tool to both healthcare professionals and also to inform the patients. And so I would like to thank you as listeners and of course our two speakers very much. And you can see also how you can get in touch with us here. And I will now stop my presentation and will hand over to Maurizio. Maurizio, we're really looking forward to your exciting talk. Thank you very much for coming.
Thank you, Gerd, very much for your introduction. That let us now to spend less word to explain. I try now to share my slides just to start this presentation as announced. And I think that this section regarding the role of the mechanism that make possible the transition from primary to secondary are really important because all we know what is Raynaud phenomenon. Raynaud phenomenon is I can say in some way a physiological reaction, usually to the cold, but not only to the cold, because the primary Raynaud is based on the reactivity of sympathetic nervous system to different stimuli, and is reversible. Reversible, so there are no apparently damages that may be recognized, excluding the change of colors that is related to the vasoconstriction and vasodilation, continuous. This is, of course, itself a stress for an endothelium. But what is important is to understand how we move to this benign primary phenomenon to the secondary Raynaud phenomenon. Generally, the secondary Raynaud, the primary Raynaud phenomenon is reversible and is symmetrical. So both the hands, all the fingers are altered, and we will see what happened at the level of microcirculation. The secondary Raynaud phenomenon is less reversible, is not always reversible because it's based on the damage of the tissue, the damage of the microcirculation that is now, of course, symmetrical. And so even the appearance, what we will see on the capillaroscopy, makes difference between finger and finger. In any case, the capillaroscopy is the most safe and reliable system to detect the changes. And this microvasculopathy that starts around the vessel, that is due to different causes we will discuss, is the beginning for the progressive lesion of the endothelial cells and of the vessel itself, and so the dilation of the vessels. This is the earliest signals of damage of the microvessel, the dilation, a dilation that is progressive. And so we know that capillaroscopy was introduced in 1973 by Hildegard Marek, and then finally in 2000 start the classification of different steps of the progression, and finally in 2013, the Euler and ACR included in the classification guideline for systemic sclerosis mandatory the evaluation of the microcirculation. But how much primary cases become secondary cases of Raynaud phenomenon? This study, published in 2006, looking at the diagnosis by associated symptoms, found that 11% of people with primary Raynaud phenomenon might be identified affected by secondary, based on clinical symptoms. We tested this transition looking at the changes of the microcirculation. So looking at the microvessel situation status in primary and secondary, following a large number of patients, and was identified looking at the changes of the structure of the vessel, almost 14.6% of primary phenomenon become secondary phenomenon and are captured very at the beginning with capillaroscopy before some organ are affected and appear the clinical related symptoms. And also in a shorter period, not of 9 years like in the clinical study, but in 29 months. So you can see here the transition from normal to early, almost 4.6%, and transition from early alteration, dilation, to early, another 10%. So at the end, 14% of transition. And this is really interesting because we can have a sort of a prediction of the progression from the primary to secondary in a very safe way. And this, the appearance of the giant, represents mandatory signals and recognized now like the first signal of transition from a benign reactivity of the microvessels, reversible, to a progressive and damage of the microvessels. But what happened pathophysiologically? How slowly we moved from a primary condition to a secondary condition. All is based on the microvasculopathy, so the damage of the endothelium that is progressive. And this damage, of course, is responsible not just for this microvascular feature, but also for the changes of the connective tissue. That means the progressive fibrosis. So the microcirculation damage is also the beginning of the wound healing in some way, the fibrosis that follow the damage. Which are the trigger? There are several triggers. For example, this interesting study in Spain showed that after 20 years looking at the capillaroscopy of workers in contact with vinyl chloride, so chemicals, showed after 20 years some changes, as you can see here, in the structure of microvessels, a sufferance of microvessels, with even some loss of capillary, in any case, some tentative of angiogenesis, like a situation of hypoxia in the tissue. But much more important is the role of the estrogen, the role of gender, that is involved in both primary and secondary. In primary, Raynaud, we know that much more frequent in young female, young girl, the change in the vasoactivity of the vessels, and this is due to the high concentration of adrenal receptor for norepinephrine. This is much higher the expression during the fertile age and is responsible for the higher reactivity of the microvessel in female compared to male. This, of course, may cause easier vasoconstriction and vasodilation in the stress and in many other conditions. But what is interesting is the role of estrogen in secondary renal phenomenon that is associated with an autoimmune disease. Estrogens are known an answer of the B cell reactivity, so the adaptive immunology, immune response, and the B cells in particular produce more antibodies if something is wrong. Alteration, for example, of the endothelial cells, they release antigen from the nuclear, from the cytoplasma. And so it's clear that usually all the autoimmune disease, chronic autoimmune disease, due to this enhanced activity of estrogens, is much more frequent in female compared to male. You can see here for the most important connective tissue disease. But in systemic sclerosis is very interesting to see the production of the so-called functional antibodies. So antibodies produced in the area of the vasculopathy against, for example, angiotensin receptor, endothelium receptor, estrogen receptor, that act as agonists. So in few words, such kind of antibody is not just marker of the increased immune response, but also are active actors and exert vasoconstricting activities, so are involved in the early steps of the pathophysiology. This is a very important point, the presence of functional antibodies at the site of the earliest immune response when are released component of the cells are not anymore protected, but become antigen. This microvasculopathy increase the local production of different products, including growth factors. High concentration of vascular growth factors, TGF beta, fibroblast growth factors, and you see as around the vessels start the fibrosis and the tissue become more and more fibrotic. And this is the beginning of systemic sclerosis. So the microvasculopathy can start with the damage of the vessel. At the end is the trigger for a cascade of the events that in the normal wound healing stops, but here never stops, sustained by the continuous production of cytokines and growth factors. And so it's clear that the vasculopathy, the immune response, is the beginning for the fibrotic. And here, 20 years ago, was discovered a very interesting aspect, the transition from endothelial cells to mesenchymal cells. So in other words, the damaged endothelial cells become myofibroblasts. And the same happened for epithelial cells in the lung, for example. during interstitial lung disease, the reduction of the vessel, the destruction of the vessel even, transform the apparatus of the endothelial, the epithelial cells in cells trying to repair that damage. And the repair is fibrosis. That is tremendous. So the first signal of secondary renal phenomenon is the progressive capillary dilation. That is the beginning for the formation of giant capillaries, and then they collapse and loss of capillaries. So we have mainly three classical patterns: the early, giant, active, increase of damage, and late, fibrosis. You can see the yellow background is a fibrotic skin, and the angiogenesis with arborization that you can observe. These are three classical aspects. But in 2016, we started a study, a large study, over 6,000 images in 200 almost patients, looking at the diameter. We know that up to 20, the capillary is normal nanometer, but over 50 micrometers is a giant. So what happened in between 20 and 50? Is there a threshold, a risk? Well, this study showed that when you have a dilation, a number of dilation, a large number of dilation under 30, this is a micrometers, is a negative predictor factors for the progression to giant. But when you have a dilation over 30 micrometers, here you start to have something at risk of progression. So the transition when you have a diameter over 30 micrometers to the early pattern to the giant is around 70 months. But if you have a less, it's more than 40, 24 months over a total time, an average time of 4 years. A second study went to evaluate the range between 30 and 50, because 30 and 50 and over 30 represent a risk. And here the results are very, very, very interesting, because it was observed that when you have around two capillaries over 1 linear millimeters of two capillaries over 30, here over 4 years, the risk for transition to giant and to secondary is very high. And you see the classical early pattern may appear, and with the classical dilation over 50 micrograms. So we have a sort of pre-scleroderma signature that we call up to now very early signal or pattern. We are working now on thousands of patients to see if the earlier observation by Koenig in 2008, that in this nice diagram showed how you have a first dilation, then capillary loss, then angiogenesis, and finally defined systemic sclerosis. This at that time was not used. The pattern is strategically corresponding to the early dilation, to the active, the increase of loss of capillary, and finally to the late with angiogenesis. The three different morphological changes observed by Koenig were now classified as early and active and late pattern. So the crucial role of progressive dilation is a signal of progression. And the two studies I mentioned showed that there is a predictive values, positive predictive values when you are between 13 and 50. So before giants, you have to look how many capillary are in 1 linear millimeter over 30. If over 2, this is patient must be observed carefully, because in maximum 4 years it will present classical giant, and so this is the classical early, and by definition is a secondary Raynaud with the giant capillaries. So at the end of the story, we have this sequence: very early signature, early, active, and late. And now I would like to introduce, like Gerd already mentioned it, Vanessa Smith, that will present practically how to distinguish this background that I try to describe from the pathophysiological mechanism. Thank you, Vanessa.
Thank you so much, Professor Boermester, and thank you so much, Professor Cutolo. I'm trying to share my screen. It's my honor to give this second part of the webinar today, and as Professor Boermester kindly introduced and Professor Cutolo also said, I will say something about the role of capillaroscopy in detection of secondary Raynaud's phenomenon due to systemic sclerosis and scleroderma spectrum disorders. As Professor Boermester mentioned nicely in the beginning in the introduction, when you see a group of patients having Raynaud's phenomenon, you may wonder which has primary Raynaud's phenomenon and which has secondary Raynaud's phenomenon. And do we have to scare all of our patients or can we reassure patients? Well, this is the pie with all patients of Raynaud's phenomenon. And you can see that by and large, the largest group has primary Raynaud's phenomenon. So it's up to us as rheumatologists to be able to discern who has a primary Raynaud's phenomenon and who belongs to the 10% who has a secondary Raynaud's phenomenon. As rheumatologists, we have concerning connective tissue disease very nice criteria to help us in clinical practice to discern a primary from a secondary Raynaud's phenomenon. And these are the Leroy's 1992 criteria. First of all, a primary Raynaud's phenomenon there is defined as not related to a condition. And as I mentioned, it occurs frequent in the general population, has a familiar predisposition, typically young age of onset. Per definition, there must be no digital trophic lesions such as digital ulcers, and importantly, and this is what people sometimes forget, before to call it primary, Leroy said you must have a negative anti-nuclear antibody and a normal capillaroscopy. Normal meaning not a scleroderma pattern. And we'll come back to that later. Before we continue, I would like to thank Professor Carmen Pizzorni, who was the one to teach me capillaroscopy in 2008. So I'm speaking about a primary Raynaud's phenomenon having a normal capillaroscopy. What is a normal capillaroscopy? Well, you have stereotype normal fairy tale world, like you can see here, a wedding hairpin. Their capillaries have the shape of a hairpin. I'll use my pointer. Their capillaries have the shape of a hairpin and lie on equal distances to each other. That's the fairy tale world. If you look in between us in this room, not all of us are fairy tale perfect. So here you have the Euler SCTC consensus, which is meant to standardly evaluate and describe capillaroscopy. You have stereotype normal, like the image you saw on last slide, hairpin-shaped capillaries lying on equal distances to each other. But with the Euler SCTC consensus, we always, before to decide on whether something is normal or belonging to scleroderma spectrum disease, we always describe certain characteristics. First of all, the density, which is measured closest to the nail and should be more than 7, like on the image of last slide. But sometimes you're not totally perfect. Here, for example, you have 5 capillaries in a linear millimeter. This is a non-specific abnormality of density. You also evaluate other capillaroscopic characteristics, such as dimension. As Professor Cutolo said, dimension we measure apically, and it should be less than 20 micrometer in a stereotype normal world. But some of us in this room may have some change in apical diameter, and we call this a non-specific abnormality of dimension. The third capillaroscopic characteristic, and I take you to the right part of the slide, is morphology. Morphology or shape of the individual capillaries is normal when it's hairpin shape. When it's tortuous, this means that the tip is convex but the afferent and efferent line undulate, or when the lines cross once or twice. This is stereotype normal, but sometimes in a healthy control population, you may have a not normal shape, as you can see in this very image. And lastly, in healthy controls in a stereotype perfect, you don't have microhemorrhages, but sometimes you may have some microhemorrhages. So normal and non-specific abnormalities of the capillaroscopic characteristics is what we have in healthy controls and what we have in primary Raynaud's phenomenon. In secondary Raynaud's phenomenon, due to any connective tissue disease such as lupus, you may have the same as in healthy controls, perfectly normal, non-specific abnormalities. It's only in systemic sclerosis and diseases of the scleroderma spectrum that you have the scleroderma patterns, as Professor Cutolo already hinted at. The early scleroderma pattern has a normal density, but has, as Professor Cutolo mentioned, giants. Giants are homogeneously enlarged capillaries with an apical diameter of more than 50 micrometers. In the active pattern, you have the combination of a lower density, because systemic sclerosis is a disease with obliteration of the microcirculation, so a lower density combined with giant capillaries and microhemorrhages. We'll show a picture of that on the next slide. And in the late scleroderma pattern, you have an even further reduced density. Here you only see 2 capillaries and vastly abnormal shapes. We call this the late scleroderma pattern. I promised to show you pictures of the scleroderma patterns according to Cutolo. Here you have the early pattern with giants, the active pattern with a lowered density, because I only count 1, 2, 3, 4 capillaries here. In a normal situation, you should have at least 7, with giants and microhemorrhages. We call this the active pattern. And this is a nailfold videocapillaroscopic picture with a 200 magnification of the late pattern. These are vastly abnormal shapes. We call this neo-angiogenetic shapes. And in 1 linear millimeter, the linear millimeter you can see by the blue lines, I only have 3 capillaries. This is a late scleroderma pattern. It may not be easy in the beginning when you execute capillaroscopy to discern scleroderma patterns from non-scleroderma patterns. And we'll see in a minute that, however, these are very important to help you in daily practice to see who will get definite systemic sclerosis or not. But with the Euler study group on microcirculation and rheumatic diseases, we have prepared a fast-track algorithm, which teaches to novices in a very short time to characterize an image in front of them as a scleroderma pattern or a non-scleroderma pattern. And the nice thing about this fast-track algorithm is that it has a very high inter-rater reliability versus people who had never executed capillaroscopy versus the gold standard. And we tested it as Euler courses and validated this inter-rater reliability at Euler courses. If you're interested in this fast-track algorithm, you can find this article for free online, as well as exercises on how to apply this fast-track algorithm. So I promised to also give you some clinical tips, how to investigate a patient with Raynaud's phenomenon. Well, logically, we do a full blood count, we check for a sedimentation rate, we check for antinuclear antibodies, because if they're positive, you can't call it a primary Raynaud's phenomenon. And we execute nailfold capillaroscopy. Always, we must take a full history and a full clinical examination. And I'll show to you in a minute a case why we should do that. Of note, when your Raynaud's phenomenon is unilateral, we send to vascular medicine to check if there's a macrovascular abnormality. It's not within the remit of this lecture to speak of all causes of cold hands and Raynaud's phenomenon. As a rheumatologist, we look in the group of connective tissue diseases, but just to tell you and to inform you that there's other causes of cold hands, such as thromboangiitis obliterans, thromboembolic disease, or even just in internal medicine, people who have atromatosis. So it's always very important to take a full history and a full clinical examination. Of course, as rheumatologists in our daily practice, we mostly get people with connective tissue diseases, but a little bit more about that later. Just to show you this case, to reinform you that you always must take a full clinical history and clinical examination. This 53-year-old translator from Romania came to us telling she had since 3 weeks Raynaud's phenomenon and these lesions. Luckily, we had a very diligent assistant who saw this lady and noticed this tumor, which unfortunately had already expanded to the lungs. just to show you again that even in our outpatient clinics, when patients just come with cold hands or digitrophic lesions, always fully check the persons clinically and also on history. What do we get most in our daily practice? As rheumatologists, we mostly get patients referred to us with just the Raynaud's phenomenon, no accompanying signals of connective tissue diseases. And the largest study evaluating a group of patients with only Raynaud's phenomenon and no other signal of connective tissue disease was this large North American study. They evaluated 784 patients with just the Raynaud's phenomenon. And they saw that 13.6, and this lies in line with the smaller studies that Professor Cutolo showed you, 13.6% will get a secondary Raynaud's phenomenon. But what was very nice about this study is that they show that of the 13.6, 12.6% gets definite systemic sclerosis. And this is why if a patient only has Raynaud's phenomenon at baseline, we screen for systemic sclerosis. And we need to thank two important people who have helped us how to screen these patients. The late Professor Marek, who used the wide field technique, showed that if in at least two fingers you have two of these big ones, I showed that my arrows move, but two of these big ones, you're dealing with a scleroderma spectrum disease. And this was adopted by Professor Cutolo with a nailfold magnification of 200. If you have one giant, you must watch out to see if this patient develops systemic sclerosis. Which validated sets of criteria do we have to corroborate this? Well, first of all, we have Leroy, who said in 2001 that if you have the combination of Raynaud's phenomenon, a scleroderma pattern with giants, and systemic sclerosis-specific antibodies, that you have a high chance to transition to definite systemic sclerosis. The Leroy's criteria were validated by the study of Koenig, because Koenig showed that indeed, if you have this scleroderma pattern, systemic sclerosis-specific antibodies, and the Raynaud's phenomenon, then in 65.9%, you transition to definite systemic sclerosis within 5 years. Conversely, Koenig also showed that if you don't have a scleroderma pattern, if you just have the Raynaud's phenomenon and no systemic sclerosis-specific antibodies, then your chance to transition to systemic sclerosis is low. Some people thought that this would flood our outpatient clinic, so Professor Matucci introduced an extra criterion, puffy fingers, and he called these criteria, lying in line with the Leroy's criteria, the VIDAS criteria, saying that if you have one or two of these VIDAS criteria, more specifically Raynaud's phenomenon, anti-nuclear antibodies, puffy fingers, systemic sclerosis-specific antibodies, or a scleroderma pattern, that you're at high risk to develop definite systemic sclerosis. And these criteria have also been validated. This follow-up study shows that if at baseline you have puffy fingers and systemic sclerosis-specific antibody, that in 94.1% you get definite systemic sclerosis within 5 years. This study also corroborated the Leroy's criteria, stating that if you have a scleroderma pattern on capillaroscopy and systemic sclerosis-specific antibodies, then in 82.2% you get systemic sclerosis within 5 years. So resuming, what have we seen here concerning capillaroscopy in daily practice to discern a primary Raynaud's phenomenon from a secondary Raynaud's phenomenon, based on the Euler SCTC consensus to make an interpretation of capillaroscopy? In a healthy population, you and I, stereotype images may be stereotype normal. Remember the wedding pin we saw at the beginning of this lecture. But you and I may have non-specific abnormalities in density, in dimension, in morphology, or we might have microhemorrhages. In any connective tissue disease, for example, lupus, you may have stereotype normal or you may have non-specific abnormalities. In systemic sclerosis and diseases of the scleroderma spectrum, such as mixed connective tissue disease, inflammatory myopathy, and systemic sclerosis, you may have with a 200 magnification the early active or late pattern, according to Cutolo, and with a wide field technique, as Marek has executed, you may have definitely enlarged capillaries. Having said this, I would like to thank again Professor Cutolo, who started teaching us on capillaroscopy more than 20 years ago. And all of us, Professor Cutolo, Professor Burmester, and I are happy to take any questions. Thank you so much for your attention.
So thank you very much, Vanessa and Maurizio, for these excellent presentations, which of course are very, very helpful in daily clinical life. And for those of you sitting at the monitors and TV screens outside, please use the questions and answer button that you will find at the bottom of your screen. I will also monitor the chat, so you can also use the chat, but please enter your questions into the question and answer box if you have some. And I would like to start with a few questions that came already up. Maybe I can start with you, Vanessa. You have a patient sitting in front of you with, let's say, benign primary Raynaud's phenomenon, 25-year-old lady who complains, well, when she rides the bicycle in the wintertime, she has Raynaud's phenomenon, and she has already gone to Google her condition, and she says, oh, it might be quite likely that I will eventually develop a systemic sclerosis, which she thinks is a very, let's say, difficult disease to manage. How do you inform your patients and give them some trust that ultimately it will not be that bad?
Thank you so much, Gert, for this very nice question. First of all, when I have a 25-year-old lady who's biking in Belgium, which is mostly cold country except for today and yesterday, sitting in front of me, I will test anti-nuclear antibodies, I will test systemic sclerosis-specific antibodies, and I will see with the fast-track algorithm if she has a scleroderma pattern or not. If not, then I will reassure her and I will tell her that based on the study of Koenig, she has less than 5% to ever develop systemic sclerosis. Maurizio also told us something different. If in this lady we see in several fingers, several dilated capillaries more than 30 micrometers, then for academic reasons, I will follow her up to see if she converts later on to a scleroderma pattern or not. But Professor Cutolo also mentioned to us already, we first need large prospective studies to see how that can help us in daily practice. But again, I will reassure her if she doesn't have a scleroderma pattern and if she doesn't have systemic sclerosis specific antibodies, I will reassure her. Even if she has systemic sclerosis specific antibodies without a scleroderma pattern, then I will tell her that based on Koenig, she has only about 20% to ever develop this disease. And I will explain to her that Raynaud's phenomenon is a very frequent, up to 10% in our northern countries has this, whilst systemic sclerosis only occurs very rarely, 1 over 10,000. What I will tell her to take away her being scared is when she gets white fingers, I will tell her that this is not deadly, that she will have to protect herself against cold to have less occurrence of these white deadly fingers, but that they're only a symptom and that they're a functional symptom, that they're not dangerous. Thank you so much for this question.
Yes, thank you, Vanessa. And now the patient reveals, well, Professor Smith, I must admit I'm smoking 20 cigarettes a day. I don't want to give that up. What do you do?
Then I will tell her that I don't judge her. In Belgium, we have people to smoke. In Belgium, we have people to use marijuana, all things that give vasoconstriction. I will tell her I don't judge her, but that she should really stop smoking.
Yeah, right. Thank you very much. Next question already in the chat. Maybe Maurizio, you can answer it. How often should we perform capillaroscopy in a patient with benign Raynaud's phenomenon? So every year, every half year, every 2 years. How do you do this in your clinic?
Yeah. Okay. This depends from the condition you start at baseline, your Raynaud. I mean, if your Raynaud is, for example, as I mentioned, in this pre-scleroderma signature, so you see a lot of dilation that is not normal. This is something that's growing, that the mushroom don't grow in one night, even sometime, but grow progressively. And so here is suggest every 6 months. Of course, if you already have an early pattern, because there are fast progressors and slow progressors, in any case, at least 6 months to realize that change the number of the shape of the capillaries would be suggested. Of course, if you are in the late pattern, when unfortunately fibrosis is present, you have already involvement in organs, might be lung and even gastrointestinal. Here, the role of capillaroscopy is much less important because it's difficult to observe any variation. You cannot have any more giant because they are totally dead, the normal capillaries, only angiogenesis. So here, even every 1 year. So it's very important as dilation represents a prescleroderma signature, much more than any other clinical symptoms. For example, swollen fingers are a consequence of the damage of microvessels. So if you have a swollen finger, it's not very early, but it's something that follows a very early damage. So the very early signal is the dilation, progressive dilation, and exudation of fluids up to the collapse of giant. So regularly every 6 months, it's okay. If I have a signals, when is over disease every year, it's okay.
Thank you very much. And Vanessa, I think we cannot avoid the question that came up is our 25-year-old young lady has agreed to stop smoking, but she says, well, I really need treatment. I use all these gloves in the winter time, but I still suffer from this Raynaud phenomenon. Don't you have a medication for me?
I will say, yes, we have medications, but mostly I ask to young girls, do you walk around a t-shirt like this outside?
Yeah.
Do you wear a hat? Do you wear merino wool? If yes, do you wear electrical heated gloves with electrical threads running around your fingers? Mostly they say no, because mostly they don't wear a hat, they don't wear merino wool, and they walk around in winter in a t-shirt like this outside when it's 0 degrees. But if they do that, then we mostly, if necessary, if they really want, we give calcium channel blockers. But we also say to young girls that calcium channel blockers can have side effects such as headaches, such as ankle swelling. So I always ask them what is the benefit in their personal life versus the non-benefit. Mostly if they do dress like they should dress in colder climates, then they're fine with that. But yes, there is medications that we can give to them, but they also have side effects.
Thank you very much. Vanessa, the next question, Maurizio, is the doctor calls me and said, well, you have convinced me so much of the value of the capillaroscopy. Now I want to buy equipment, but I'm a very, very poor doctor. I don't have much money. I just cannot afford the expensive microscope. Can't I get a watchmaker's microscope, or what would you suggest in, let's say, in a poorer environment?
Yes,
Maurizio.
it is a classical question, of course. And I can tell you that just to look at the morphology, the very evident change, I mean, dilation, giant, is a sufficient USB device that costs $70, 70 euros. But where is the problem? That for the screening at the bed or in the office, it's okay because you can say, looks a giant, but you cannot measure the diameter. Maybe 40 is not yet a giant, and you already say you have a scleroderma. And this is a terrible diagnosis without a precise parameter. First. Second, the follow-up is impossible because you cannot store the imaging and make the difference over the time, especially the number of capillaries over 1 linear millimeter, because you need the software for that. And third, it's clear also if you start a therapy, you cannot appreciate really with such magnification that usually is not up to 100 magnification, but less, the real evidence. So for the first screen is perfect. In your pocket, it's okay. Even a dermatoscope is perfect if you already have. Ophthalmoscope is okay. 20 magnification is okay. But you cannot give the final decision, a final diagnosis. You can just be alerted, and you should send to an office where they have at least a microscope, but better, a video capillaroscope to evaluate a parameter that may definitely make the diagnosis of secondary Raynaud related to a connective tissue disease.
The Americans,
No,
Maurizio,
thank
to
you.
add on to
Yeah.
the Americans to add on
Vanessa,
to
just
what
go ahead. Mhm.
the Americans, to add on to what Maurizio said, actually evaluated this question because, as we know, in America they mostly have dermatoscopes. And they made a comparative study in which all American patients got dermatoscopy, which is cheap, and videocapillaroscopy. And the bottom line of that study was, it's published by the group of Tracy Freck and Marcus Snow, together with Misa Fradik, is that with a dermatoscope, which is cheap, if it's a definite scleroderma pattern, you can find it. But you may have a lot of false negatives with the dermatoscope. And this is the exact reason why Maurizio said you should always send to a center which also has a 200 magnification. Thank you so much.
Great answers. And so we are coming to the end, and I cannot avoid, I'm afraid, one question. Maurizio and Vanessa, when will you and the experienced rheumatologist in nail capillaroscopy be replaced by artificial intelligence so that you just put that there is a nurse in front of you placing your fingers into a device and artificial intelligence will tell you the pattern? Is this just crazy science fiction, or will that be possible in the future? Maybe to both of you, just as ending our great seminar.
If Vanessa, I start.
Of course you start.
Yeah.
Pleasure.
Oh, 8 years ago, we were among the first to use artificial intelligence to count the capillaries in the pictures, fixed pictures. And was a terrible work with engineering and specialists to avoid that hemorrhages may be counted like capillaries. You can imagine how many bias and bag. But at the end, using a combination of pixel, colors, and surrounding and avoiding the lesion, they are not in continuity with the other vessel. We finally produce a software that is now working in different systems and used regularly to count automatically. Okay, and we also made some study published comparing the same picture evaluated by a human and by the software, and there was a very good overlap. So no problem. The problem is that when you use such counting, then you have a number, but you cannot say a diagnosis. Because, for example, if you don't evaluate the diameter at the same time, the number of microhemorrhages, and so on, the final interpretation of the images must be related to many other factors, because usually we observe 16 different sites, 2 for each finger, 8 fingers. The thumb is not considered. And then we make an average of all of this data, and the interpretation is related also to all the parameters I mentioned in my part, and also Vanessa mentioned. So in this case, the artificial intelligence may help to count, but it is just a support, and you cannot make a diagnosis counting the capillary, even if this is the main parameters to follow the patient.
Thank you very much, Maurizio. Vanessa?
Yes, I would like to add on to I would like to add on to Maurizio. There's system, like Maurizio says, who count capillaries. There's also system in research center settings from other groups which can make as well a diagnosis as a human. But these are systems in research setting not being sold in daily practice. So I'm sure one day there will be systems which can replace humans, but we must think about our policymakers and what can be reimbursed. So at this very moment, I feel very safe that we have a fast-track algorithm, which we can easily train any medical doctor with, and they can classify an image as scleroderma pattern or not. If one day there will be AI, I will be very happy. But then again, in Belgium, we will have problems because these will be very costly tools, and for sure they will not be reimbursed by our Belgian governments. And I don't think it's a lot better in the rest of the world at this very moment. So I hope there will be systems but I don't think they will be reimbursed. So for this very moment, I feel very safe with a fast track algorithm to classify fastly and easily and reliably in daily practice. Thank you so much.
So thank you very much, dear speaker. So it was really great, Vanessa and Maurizio. Very, very helpful, I guess, and also in daily clinical practice. So we started with Maurice Raynaud, who detected and discovered Raynaud's phenomenon in the 19th century. And we ended up with a look into the future with artificial intelligence and how to use the capillaroscopy in daily clinical practice. Very, very important findings and of course of great practical value. So I would like to thank you and the audience for listening, and I wish you all, I'm afraid sort of a hot afternoon, but hopefully it will cool down eventually, and so enjoy the rest of the day, and bye-bye for now.
Thank you,
Thank you.
Gerd. Bye-bye. Ciao, Vanessa. Ciao, Gerd. Thank you very much.
Ciao.
Thank you so much.